Hello and welcome back to EpiDecoded. I'm Dr. Arora, and today we're tackling a topic that's as vital as it is sensitive: death rates. Or in epidemiological terms, mortality measures. Now, I know, when we talk about epidemiology, death can sound like a grim topic. But the truth is, measuring mortality is one of the most powerful ways we understand the health of a population. It helps us answer questions like, what's killing people? Who's most affected? And importantly, what can we do about it? Because behind every number is a person, a life, a story. And our goal in public health is not just to track death, but to learn how to prevent it. Let's begin with the most straightforward term: crude mortality rate. It's simply the total number of deaths in a population during a specific time period, usually expressed per 1,000 or 100,000 people. For example, if 8 out of every 1,000 people in a city died last year, that city's crude mortality rate is 8 per 1,000. It gives us a broad sense of the overall burden of death. But here's the catch: crude rates don't account for differences in age, and age plays a massive role in mortality. Imagine comparing a retirement community in Florida to a college town. Even if both are equally healthy, the retirement community will have a higher crude death rate, simply because its population is older. To adjust for that, we use age-specific and age-adjusted mortality rates. Age-specific mortality breaks down death rates by age group. For instance, how many infants under 1 year died per 1,000 live births? That's the infant mortality rate. And it's one of the most sensitive indicators of a country's overall health and development. Age-adjusted mortality allows us to compare populations with different age structures fairly. We adjust the data to a standard age distribution so differences reflect health outcomes, not just age differences. This makes it possible to compare, say, cancer mortality in two countries: one with a young population, one with an older one, on equal footing. Now let's talk about cause-specific mortality. This refers to the number of deaths from a particular cause, like heart disease, cancer, stroke, or injury, within a population over a certain period. It helps us identify what is driving mortality trends. Back in the early 1900s, infectious diseases like tuberculosis and pneumonia were the leading causes of death. But today, in many countries, chronic diseases have taken over: cardiovascular disease, cancer, diabetes. This transition from infectious to chronic causes is known as the epidemiologic transition. It reflects not just biology, but changes in sanitation, medical care, lifestyle, and aging populations. Knowing which causes are rising or falling allows us to allocate resources wisely, design prevention strategies, and evaluate how well our health systems are working. Another important concept is the case fatality rate, or CFR. This tells us, Of all the people who got a specific disease, how many died from it? It's a measure of severity, not just prevalence. If 1,000 people contract a disease and 50 of them die, the CFR is 5%. This is especially important in outbreaks. It tells us how dangerous a disease is once someone is infected. For example, during early Ebola outbreaks, CFRs were extremely high, often over 50%. COVID-19, in contrast, had a lower CFR overall, but spread far more easily, leading to a much larger total number of deaths. We also use proportionate mortality, which looks at the proportion of all deaths that are due to a specific cause. So, if 1 in every 4 deaths in a country is from heart disease, we say heart disease accounts for 25% of proportionate mortality. It doesn't tell us risk, just where the burden lies. Numbers alone don't tell the whole story. We also care deeply about when death occurs. That's where years of potential life lost, or YPLL, comes in. YPLL places more weight on deaths that happen earlier in life. A death at age 30 contributes more YPLL than a death at 80. This helps us prioritize prevention efforts for diseases that strike younger populations, like trauma, overdose, or certain cancers. It reminds us that the impact of death isn't just about frequency. It is about the time. The potential, the life cut short. Let me bring this together with a real-world perspective. When we look at mortality data, whether it says from global databases or a local health department, we aren't just tracking numbers. We're reading a story. A story of where we've succeeded, where we're falling short, and where we need to go next. For example, if a country sees a decline in infant mortality, it might reflect improved maternal care, better access to health services, or cleaner water. If another sees a rise in drug-related deaths, it might signal a mental health crisis or gaps in addiction treatment. Mortality data is a mirror, and sometimes it reflects uncomfortable truths. Disparities by race, income, education, or geography can show up starkly in death rates. And facing those numbers honestly is the first step to creating a more equitable health system. So what does all of this mean for us, as epidemiologists, as health professionals, and as people? It means that measuring mortality is about more than counting the end. It's about understanding what led there and how we can change that path for others. It's about seeing each data point as a life and using that knowledge to protect the ones still unfolding. That's all for today's episode of EpiDecoded. I'm Dr. Arora, and I hope this conversation gave you new insight into how mortality measures do more than track loss. They illuminate opportunity. In our next episode, we'll shift gears and explore the science behind screening and diagnosis, and ask the question, can you trust that test? Until then, stay thoughtful, stay informed, and stay well.